So why don't we open up for about 10 minutes or so of questions before we go to the summary phase. John, let me start with the questions. You made the comment, which I really like, and I believe that things will emerge to help me whether the system does it or not. But you made the comment that you hope the system does because you have some implicit trust in the system. Can you talk a little bit more about that? Because the other issue is people just doing stuff, and I think one of Devin's concern is how do you trust the person who ran your who ran an analysis on your genotype? You're a sophisticated consumer. We not all of us are.
Yeah, I mean, ideally I would get this with my doctor, but that's hard. You know, I go to a doctor who actually spends 2 hours a year talking to me, which is really rare, and is willing to engage with me on these kinds of issues. But I think that makes me a significant outlier in a lot of ways. I mean, I would like to be able to participate in a system where the transparency of the analysis and the transparency of those who participate in doing the analyzing is evident, because it's one thing if someone who annotates my genome is a genomics professor in the UK, like the email I got from the gentleman about my pedigree. But I had to Google him and I had to look it up. And it's a very different thing if it's, you know, John's molecular biology blog claiming that I have, you know, 3 weird SNPs that cause me to have autism, for example. And I'm really worried that in the interstitial period where it's easy to generate data but hard to analyze it, that people are going to look for false hope and they're going to find high-dimensional correlations that aren't causal, and they're going to take actions on their health that aren't very good for them. And that's something that trust in the system actually can help us get at. But the problem is that the rate of change of this system is so slow that it'll be hard to get meaningful information out of it during that same interstitial period. And so I don't have a solution. I just know that it's a problem and it's a tidal wave, and we don't even have a surfboard.
We'll go to the microphone.
Steve Weiss, MedData. On your point, thank God we have the FDA, because as soon as the person who did your analysis asks for a check, we have somebody to protect us. And that's Dr. Woodcock's agency's responsibility. But my question goes to our mission collectively here. We're here to save lives. And I went through the AIDS crisis back in '84, '85. And there were definitely legitimate concerns about knowing somebody's HIV status and the consequences on them in terms of discrimination and use. And we balanced it at that time in terms of public policy concern led by the American Public Health Association, and we didn't do a national compulsory test for everybody and keep it confidential, share it with the person. We weren't set up to do it. As a consequence, we wound up with an AIDS epidemic. Things you point to today, things are moving faster than we can control. FDA was saddled last year with the question of what do we do with these 3 genomic testing companies that are out there, and should they be regulated or not? We're now moving so fast with apps on the internet. You know, we have a reality changing, and our public policy can't change fast enough. We got to go through notice and comment rulemaking. Devin came up with the other idea at the Bipartisan Policy Center of writing some guidelines to get to do something to implement these principles, but they don't have effect into the regulatory bodies. Go ahead and do it. So I'm just frustrated. I'm sitting here. We've got all these great good intentions, and Devin points out, even if we come up with a model, the 50 states are never going to agree on it. So how do we solve this problem in today's atmosphere? Facebook, Twitter, the web, it's incredible. But the dynamics are moving faster than we can manage.
Okay, Devin, you get the chance to solve that. And then
well, you know, so to a certain extent, yes, the dynamics are moving faster, and there are many interesting things that are coming out of those dynamics unregulated, right? So in some instance, the fact that the rules aren't keeping up with where we're going it is nerve-wracking for me as a privacy advocate, but I don't think the sky's falling, right? If anything, we're trying to speed this up, right? And so the policy needs to catch up so that we can get the stragglers in, right? Because the innovative folks are on the train and it's moving and they're picking up speed. So, I think we work on this. I think we continue to sort of gather communities together and talk about what makes sense, what will work in the form of sort of agreed upon best practices, because the regulators may never address this in the timely way that we need to, because they have constraints of their own that they have to deal with. We can be helpful in the interstitial spaces to be able to move it forward. But it's in the meantime, it will. I mean, it is already. So it's just about figuring out how to create, I think, the mechanisms for building the trust of the public that don't disturb some of the interesting and good things that are happening, but can bring the squeamish into the fold and make sure that it remains a trustworthy environment.
And one thing that's nice about the framework idea, right, and I think it contextualizes consent nicely, is that it lends itself to a trademark authority approach, right? So before we have regulations, we could have a good housekeeping seal of approval. Yeah. For people that actually implement those proposals effectively. And so it's not just about I've consented to put my data in, but it's I can look up and see every scientist that's downloaded it, right? I can see what models it's being used in. It's that the privacy policy isn't 90 pages long. It's got a graphic interface that helps me understand what the deal is. And those are things that we can collectively create a trademark, give that to people, and only do business with people who have the trademark. And those are things that we can do well in advance of a regulation if we buy into a framework approach. So I just want to endorse that.
Carol Mimura from UC Berkeley, and my question is related to the first two. John, you put up there the portable consent document, and it also on that form had a defined term, qualified researcher. And I'm just curious to know how you define that on the form.
So when we went through IRB and we went through Western IRB on that, all of the terms you saw hyperlinked there have defined terms that pop up when you mouse over them. And we actually have a very liberal definition of qualified researcher in this context. It's someone who has signed the terms of use for the Synapse compute environment. And when you sign the terms of use, you agree not to discriminate, not to harm, not to redistribute to someone who hasn't also signed the terms of use. Basically to stay inside the sandbox that we've built, right? In order to get the low barrier of entry, you've got to stay inside the sandbox. But we also tell people in that if someone violates the terms of use that the qualified researcher signs, that we have very little power to enforce. Because this isn't property, and it shouldn't be property. I agree with Devin. It's very hard to go punish someone after they've uploaded it to a website and then someone else has downloaded it. Copyright would magically follow that if it was a Britney Spears song, but it doesn't work that way in data, and that's actually for the best. But you have to be honest about that with the user, which is that we want random people signing up for Synapse accounts and hacking on the data. And so to us, a qualified researcher is someone who has accepted the liability by signing the terms of use. That creates enough disincentive for Aetna or Pfizer or others not to screw you, because a big company is deterred by liability. What really keeps me up at night is social problems, so trolls. Someone who comes in and figures out that my kid has IBD and that's why they go to the bathroom all the time and puts that on their Facebook page, right? And I don't know how you design a contractual liability system that defeats trolling. It's one of the scourges of the internet socially, and it's going to be a scourge of the health net. But that's how we deal with the qualified researcher bit in this. And I expect that once people actually use the system, that we will be asked by the IRB to review our terms.
Microphone.
Thank you. This was wonderful. And as a patient representing patients and doing my duty, I wanted to thank you for that. And John, to also add to that, what people post on their Facebook page, when you think people are afraid of privacy, I'm kind of known in the cancer community, people will find me and tell me things that I don't want to know. So part of it is we need to put this in context of where we are today, and we need to move forward. I am afraid of patient. You take any noun right now in the health policy debate, and you put patient-centered as an adjective in front of it, and that's what this discussion is about, okay? But patients are not capable responsible or really educated enough to have these responsibilities. And they're going to be responsible for payment, for making treatment decisions, for all of the above. And we really need a concerted effort to protect them, to inform them, and to include them. So on that note, what I'm suggesting is we need a way to have patients put their information into electronic health records. And just because we put it there doesn't mean they're going to do it, but we need to include them, and we can't be they're a silo themselves, because you could lead them to water, but they're not going to drink. But we need to include them in all of these decisions because they're making decisions anyway, and their doctors aren't informed, et cetera. So we really need to think about what the result is of what we're trying to do.
Thank you. Steve?
First, thank you for both of you, because I think bringing us into this big, wider world is an important, eye-opening introduction. I have a question for two of you. One is well, both of you could answer this. First is, my impression was HIPAA was really instituted for misuse of health information by providers, insurers, whatever, and that they really didn't think of the ramifications for research. And I was told, and I would love to hear from you, is that there were plans, perhaps in the current environment, impossible, to revisit HIPAA to reduce the interference with the smooth functioning of the research system. I think a lot of what we're hearing here were unintended casualties of HIPAA. This was not the misuse, I think, that was being envisioned. So I'd like to hear your comment on that. And second relates to a bunch of comments that, John, you made, and I don't understand the full scope of SAGE, but you said repeatedly that you were getting, or others were getting, from this internet data culture, things that they were frustrated, and they were getting things that their doctors weren't giving them. But to me, the kinds of reports you're getting, they could come out of a fortune cookie factory. I mean, people get frustrated that they don't get treatments for cancer that don't exist, and they go out and they get Laetrile, they go out and they get bone marrow transplant. I mean, you name it. I mean, the whole reason for the controlled system, and I'm not saying that they don't have a lot to learn from what's going on outside, is to make sure that that people don't go out and just buy what they think they want at that moment. That's totally bogus. And I don't know what any of these reports mean, and I don't know that any of them are actionable, and I suspect that 95% of them are untrue. So what does it mean to have this system, or what does it mean to you, that's giving people messages that quote-unquote satisfy a need that may, in fact, hurt them if you meet that need? So these are two questions.
So why don't you answer the last question, John, and then I'll go to Devin for revisiting of HIPAA.
So I agree with you completely. My oldest sister's autistic, and so she was born in '66, and this is back when maternal abandonment was the core theory of autism. And I've watched the autism field go through the convulsions of the last 20 years, and I think it's a good case study for how bad medicine and bad science can affect people's lives in ways that are negative. The point I'm making is not that I want medicine to be practiced algorithmically by strangers on the internet. It's that it's going to happen. Right? People already go to the internet to find medical information and treat themselves. And as they can generate more data about themselves, they're going to start going to the internet with that data. So my argument is that Pandora has been out of the box for a while, and what we need to do is deal with it. Not that I like what's happening necessarily as a sense of scientific accuracy. So, what I would like to see is the sort of place where if I'm a citizen and I read an article about a disease and a potential treatment, I can extract a hypothesis and find a way to talk and connect to an actual genomicist about it, to understand whether or not, a fruit fly experiment, right, indicates whether or not I should take a drug. Because that's the story you hear from patient advocates is, I found something about mice in Europe, and it's this drug that's part of it's a part of a delivery agent for another drug in the U.S., and I want to take it for Niemann-Pick. I'm going to give it to my kids intravenously. Right now, that is a really common story, but the average citizen who reads that has no capacity to engage with a genomicist to understand whether or not their hypothesis is rational or not. And in the absence of that, people are going to use the internet to find irrational things. So that's why my argument is we need to find a way to bring these two things together. Because if we don't, right, if the parallel tracks begin to diverge, right, this is just going to get worse, right? It's going to be like Latrell, but amplified. And that scares the living hell out of me.
Right. Thanks.
So-
That's very helpful.
So, Devin, the revisiting of HIPAA.
Sure, I know that quickly on it. So, certainly in the last proposed rulemaking that the Office for Civil Rights put out, they sought comment on a couple of HIPAA changes that might make it easier for researchers, allowing for general consent for research in some circumstances. Where they're going to go with that, I don't know. Similarly, you saw in the request for comment on some potential common rule changes, there was an effort to try to harmonize those two regulations. But certainly, you're not seeing the Office for Civil Rights saying, "Well, we're just going to take the research provisions out." Right? They're in there now, and they have a constituency that's bought into them. So, we've got to think of some other strategies, I think. Because there's gray areas within those rules that give us opportunities to move better, faster, provide for best practices that answer questions that are not currently answered well in the regulations than necessarily relying on the regulatory infrastructure. It's just, it's thoughtful, and that means it's slow. So.
All right, I'm going to, being informed that we'll have time for one more question, try to keep it brief. We will have another panel discussion. So
I'm going to try to be as brief as possible. Devin and John, maybe this is an experience that you could build on. I've just completed the complete genome sequencing on 81 executives out of the Houston area and provided that information to them. And the information is need to know. That is, did you have a disease? Did you have an allele causative of disease? So that information has been delivered to them. Now, Amy McGuire, who is in our ethics group, has now done a post-study follow-up on that study. So let me recite a few of the facts that came out of that. One, none of these executives wanted this in the medical record. None of these executives wanted this to be transmitted to any other person. 75% of them went to their doctor and discussed the outcome of the genetic study. There was only one who was dissatisfied with the information that came back, and that was, interestingly, a person who knew nothing of their family history. So it's been an interesting experience to go through, and just to recite just a couple more demographics, all had undergraduate degrees, 50% had advanced degrees. All had incomes in excess of $300,000 a year. This was not your average population, but they were grateful for the information and how it was delivered.
thank you.
Yeah, I don't know. I mean, I find that really interesting because again, you have people like John who get information and are happy to sort of share it and see what people can tell him based on his genome. Others would really, I want to see that privately. It's delivered to me. I'll have a consultation with my doctor, which, by the way, that consultation did end up probably in a medical record, even though they didn't want the information in there.
No, it did not.
Oh, they didn't put it in?
One bought more insurance.
One, okay. Okay. At any rate, I mean, it's an instructive tale. We are dealing with a population of patients who don't think about these issues in all the same way.
I mean, and so I'm going to give 30 seconds. So I think that's a great story. And what's important is the agency is at the individual's level, right? Because you've given the data back to the individual, and the individual has the agency to share it, to talk to a doctor, and I think that's important. But to sort of leave this, when we talk about patient-centered sharing or what have you, in software, in photography, in music, there's a certain percentage of the creators who like to share. And no matter how much promotion you do, that percentage doesn't change a whole lot. It's a fairly fixed percentage. It's different for each group. And my gut is that you're going to have a similar dynamic in patient data sharing. There's going to be some chunk of people who are like me, who are exhibitionists, or who are sick and have a motivation. But it's not going to be most of the population. And so the correct answer for me is not to force everyone to share or to overhype sharing. It's to increase the sample size. Because then whatever that X is for this field can create a large enough reference set of information that we can begin to do meaningful, interesting, and novel ways of doing the research. But it starts with individual agency, and it starts with individual rights.
Thanks to the two of you.